Good morning, ladies and gentlemen. Welcome to week 2, lecture 3 of the course on role of physical medicine and rehabilitation in sports. Today, we'll be discussing the functional anatomy of the upper extremity. I'll be covering this lecture as per this outline. Introduction. We'll talk about the joints of the upper extremity. We'll talk about the biomechanics, common injuries, the kinetic chain, injury prevention, ergonomics, and we'll conclude with a take-home message. The upper extremity consists of the shoulder, the elbow, the wrist, and the joints of the hand. Plays a key role in movement, dexterity, and function in daily activities and sports. Understanding the anatomy of these joints is essential for injury prevention, rehabilitation, and performance optimization. Because as you must have realized by now, most sporting activities require the use of the upper extremity. There are different joints in the upper extremity. The shoulder joint, it's a ball and socket type of joint. It allows multi-directional movement. The elbow joint, it's a hinge joint responsible for flexion and extension. The wrist joint, it's a condyloid joint enabling various hand movements. And the hand and the finger joints are critical for grip, dexterity, and fine motor skills. The shoulder joint, it's a ball and socket type of joint, and it's also called the glenohumeral joint. The articulating surfaces are the glenoid cavity of the scapula and the head of the humerus. The ligaments of the shoulder joint are the glenohumeral, the coracoacromial, the coracoclavicular, and the acromioclavicular. And the movements are flexion, extension, abduction, adduction, rotation, and circumduction. As you probably must have realized by now, the shoulder joint is highly mobile but not very stable. The flexors of the shoulder joint are the anterior deltoid, the pectoralis major, and the coracobrachialis. The extensors are the posterior deltoid, the latissimus dorsi, and the teres major. The abductors are supraspinatus and the middle deltoid. And the adductors are the pectoralis major, the latissimus dorsi, and teres major. The rotators of the shoulder are infraspinatus and teres minor being the external rotators and the subscapularis being the internal rotator. The rotator cuff provides dynamic stabilization during movement and during activity. There is something called scapulohumeral rhythm, which is crucial for proper shoulder function. By scapulohumeral rhythm, we mean when you initiate any movement of the shoulder, some muscles have to contract to stabilize the shoulder, and some muscles have to relax to allow for movement of the shoulder, and some muscles have to contract to move the shoulder. So there are different muscles which have to function at different times and in perfect harmony. The common injuries seen are rotator cuff tears, impingement syndrome, and shoulder dislocations. The elbow joint. It is a hinge joint and the articulating surfaces are the lower end of the humerus, the upper end of the radius, and the ulna. The ligaments are the ulnar collateral ligament, the radial collateral ligament, and the annular ligament. The movements are flexion, extension, pronation, and supination. So like the foot, the upper limb also supinates and pronates. The flexors of the elbow joint are the biceps brachii, the brachialis and the brachioradialis. The extensors are the triceps brachii, the anconeus. Pronation is done mainly by the pronator teres and the pronator quadratus. Supination, the main supinator of the forearm is the biceps brachii and assisted by the supinator. The stability of the elbow joint depends upon the ligaments and the muscle support, and there is high stress in the elbow joint during throwing sports, and this can lead to overuse injuries. Common injuries seen are tennis elbow or lateral epicondylitis, golfer's elbow, medial epicondylitis, and ulnar collateral ligament tears. The problem in the elbow joint is that both the primary extensors of the wrist joint and the primary flexors of the wrist joint arise from a single point around the elbow joint. And if you are doing any activity of the wrist joint, the load falls on that particular single point. The wrist joint. It is a condyloid joint and is also called the radiocarpal joint. The articulating surfaces are the lower end of the radius and the ulna and the carpal bones. The ligaments are the palmar radiocarpal, the dorsal radiocarpal, the ulnar collateral and the radial collateral. Movements at the wrist joint are flexion, extension, radial ulnar deviation, circumduction. So, flexion, extension, ulnar deviation, radial deviation and circumduction. The muscles around the wrist joint are the flexors are the flexor carpi radialis, flexor carpi ulnaris and the palmaris longus. The extensors are the extensor carpi radialis longus, extensor carpi radialis brevis and the extensor carpi ulnaris. The radial deviators are flexor carpi radialis, extensor carpi radialis, and the ulnar deviators are the flexor carpi ulnaris and the extensor carpi ulnaris. As we have probably understood by now, the balance of the wrist forces is crucial for wrist function, and repetitive movements can lead to carpal tunnel syndrome and tendinitis. Hand and finger joints. The metacarpophalangeal joint or the MCP joints allow flexion, extension, abduction and adduction. The proximal and distal interphalangeal joints are hinge joints which allow flexion and extension. And the thumb's CMC joint, carpometacarpal joint of the thumb, is a saddle joint enabling opposition. So, metacarpophalangeal joints are these joints which allow flexion, extension, abduction and adduction. Proximal and distal interphalangeal joints allow flexion and extension. And the CMC joint of the thumb is a saddle joint which allows opposition of the thumb. Hand musculature. There are intrinsic muscles of the hand such as the thenar muscles and the hypothenar muscles. The thenar muscles help in movement of the thumb and the hypothenar muscles help in movement of the little finger. There are muscles between the metacarpals, they are called interossei and lumbricals. The interossei help in finger abduction and adduction, and the lumbricals flex the metacarpophalangeal joint and extend the interphalangeal joint. There are extrinsic muscles such as the flexor and extensor tendons which originate from the forearm. Hand biomechanics depend on whether you're looking for precision or you're looking for power. The biomechanics will change whether you're going for precision to pick up something, a small object, or whether you're going for power to lift a dumbbell. Common injuries are carpal tunnel syndrome, trigger finger, and mallet finger. There is a big role of the upper extremity in movement, and it's a functional role. The upper extremity is essential for reaching, for grasping, for lifting, and for throwing. And the stability and the mobility trade-off is crucial for sports performance. You want good stability, but you also want good mobility in the upper extremity joints. The kinetic chain of the upper extremity is important because any shoulder dysfunction can affect the elbow and can affect the wrist. And the wrist positioning will influence grip strength and precision. For example, if somebody has gripped something tightly, if you flex the wrist, ultimately the grip will open. So, wrist positioning is important for grip strength as well as for precision activities. If there is a muscle imbalance, there will be effects both up and down the kinetic chain. If the upper trapezius is overactive, it can cause shoulder dysfunction. If the rotator cuff is weak, it can lead to impingement issues. How do you prevent injuries in the upper extremity? Mainly, you're supposed to do shoulder and elbow and wrist strength training to support joint stability. You may need to do mobility drills to maintain the optimal range of motion, and fine motor skills training is also essential. There is a role of ergonomics which is vital for optimal upper extremity function. If you are utilizing proper posture, it will minimize repetitive stress injuries such as carpal tunnel, etc. And the way your workstation is set up has got a lot of implications for office as well as for sports activities, because if your workstation is not ergonomically set up, you will get a repetitive stress injury and it may affect your sporting activity. The future, we are looking at better quality motion capture technology for biomechanics. Initially, we used to use markers on the bony prominences for capturing motion. Now, we are moving towards something called markerless technology. We are looking at wearable devices for monitoring muscle activity and fatigue. We are looking at artificial intelligence driven rehabilitation programs so that we can fine tune the rehabilitation on a day-to-day basis. Orthotics are increasingly being printed by 3D printers for better control and better anatomic conformance. There are several applications of regenerative medicine in the musculoskeletal system, especially in PRP, stem cells, etc. The upper extremity joints play a crucial role in movement, stability, and function. We have discussed this, we have seen this with various examples. Proper joint coordination, muscle balance, and kinetic chain function are vital for reducing injury risks and for optimizing performance. Understanding the functional anatomy is key for effective injury management, prevention of injuries, and performance enhancement in sports and in daily activities. These are the references which I have used to prepare this presentation. I strongly urge you to go through them. for improving your knowledge and for passing your exams. I seem to have finished, ladies and gentlemen. Thank you very much for continuing with this course, and thank you very much for your patient hearing. Thank you and Jai Hind.